Welcome back.
Hello. Do you notice anything about Norm and I? We're both in green. We did not plan that.
Claire looked at what I was wearing and said, "Oh, I got an idea."
Okay, welcome back. We had a good little session last week where we talked about this idea that pain does not equal tissue damage, which I think when you hear the first time, you're like, that's bullshit. No way, you know?
Yeah.
And then when you start seeing a bigger picture and hearing the other elements of like what plays into how much pain you feel at any moment, or your pain experience is what we kind of call it in pain science, you start to realize, you know, and anyone who has ever been in what they can just describe as severe, horrible pain and goes and gets an image, and that image comes back with nothing, knows exactly what I'm talking about.
That's right.
Right? You know, because there should be, right? It should hurt worse, the worse,
Right.
You know,
Right.
But that's not always the case. Today, we wanted to talk about another pain concept that we would either say that pain relies on context or pain is contextual.
Okay.
So when I say that to you, what does that kind of drum up?
Yeah, so I think of, immediately my mind goes to like an elderly person in a nursing home who may have an injury with their knee, and then an athlete in high school who has an injury in their knee.
Yeah.
And I noticed that there, you know, obviously there's those situations look very different.
Absolutely.
And so the context of that situation, there's a lot of variables going on there.
For sure.
So
our elderly lady has a belief, which we all do, that the longer we're on the planet, we're going to have pain. And we're going to break down. It's just a natural part of, you know, whatever, that's not going to bother me. And I literally was behind a gentleman in the grocery store this week because we alluded to this idea that like I can see someone with real disfigured knees and they're just trucking along, right? And I was behind somebody in the grocery store and it's just like, I think there's this understanding or this buy-in to the thought that if I get older, I'm going to have pain kind of thing. And I would argue as a pain practitioner, certainly there are more factors that will contribute to a pain experience as things break down, but getting older should not equal pain. And I'm saying that as a 41-year-old who woke up randomly with a swollen, painful knee. I am a diagnostician. I want a reason for that knee to be. Anyway, so age-related changes. But the athlete who has a season, which is a short period of time, has an injured knee, that's important.
Yes.
Right?
Right. We gotta fix this. I gotta perform.
There's pressure. Yeah. I use two examples when I'm doing my presentations that always people respond well to. One is this idea of like a paper cut, which arguably a paper cut feels pretty terrible to everyone. The reason being is that the hand has a really big sensory mapping. So we do so much with our hands that we have a lot more sensory receptors there, right? But it hurts for everyone. But if I am a professional soccer player and I get a paper cut on my finger, that's not good. I'm going to get into my game. I'm not going to think about that. It's done. I'm locked in, right? But if I'm a concert violinist, right? Yeah. And that is how I make my money. That is my livelihood. Something like a paper cut, or we could make it bigger and, you know, a major cut with stitches and stuff like that. That's way more important.
Yeah.
Not only does a violinist or someone who uses their hands have an even bigger sensory experience in their hands, it's also their livelihood. It means much more to them. So those two people with the same tissue damage, right, have a completely different experience of that situation.
You said it's interesting. You used the word that's important.
Yeah.
And so from this perspective, like you're thinking about. Just help me understand. Your brain is thinking this is important, this is not important. So if it's not important, you don't really notice it.
Exactly. Okay. Well, and it's funny because so much of our sensory experience, and if you guys go back, one of our original videos that we did was about like sensory processing, how we take things in from our environment and our brain does some, registers it. Do we need to know about it? so there's so much of that happening that we don't even know about,
Yeah.
because our brain is deciding at any moment, that's fine, that's not important, move on, don't,
Yeah.
or like you just did, you got something, I got to
Yep.
shift, right?
Yep.
Something's getting a little sticky in my back, I got to shift. But unless I've pointed that out, you're not thinking consciously of, man, my brain really thought that was important. So there's this whole subconscious factoring of what's important, what's not important. But the other thing, it reminds me a little bit of like in the trauma world, where they talk about like trauma has to have like 4 criteria for it to encode in your system as something that's bigger than just a really stressful event, right?
Mm-hmm.
And one of those things is the landscape of your nervous system at that moment, right? So the example in that place I would give is like, you have people, going to war as a soldier, seeing horrific stuff. And you have some of these people coming back and just reassimilating into life.
Right.
Yes, it was brutal. It was horrible what I saw. I'm able to detach, move on. That was a really horrific event, but versus someone who maybe at the moment of experiencing that, the meaning behind what they experience, the landscape of their nervous system, it matters, right? It hits a little bit differently. So a major injury to someone's hand who is a soccer player is less important than to someone who uses their hands on the regular,
Okay.
Well, and another example I give is I put a picture of a little kid, falling off a bike, right? And he's like looked up at the camera, and I'm like, okay, so 2 things can happen at this point. If he's with his buddies and he looks up and his buddies are like, yeah, get back on your bike, you're good.
Yeah.
He's gonna hop back on the bike and but if he's got like his mom's like, no, just like terrified, right? Like we're gonna be like, this is important, and we're gonna feel that much more. Okay, so even let's say he gets back up on his bike with his buddies. Well, then he gets home and we look down and that knee is bleeding, right? Well, we can all agree blood that's important.
Right.
Something, and so then the tears come, right? So that period of time where we weren't thinking about our knee when we were riding with our buddies,
You weren't
and
in
now, and we weren't in pain, and now we get home and we see this blood,
and now we're in pain.
and now we're in pain.
That is wild.
It's wild. It's wild. I know. And there's lots of like really cool pain experiments, which you wonder kind of who signs up for these, although I probably would. It's like the people who are like just glutton for punishment, but they'll talk about like the things in context that we know. So when we talk about like a faucet and you go up to the faucet and one is blue and one is red, we know societal, like we know what that indicates, right? Blue is cold, cool, red is hot, right? So there was a study done where they took just like a metal, stainless steel rod, which was set at a certain temperature, which was a benign temperature, right? Okay. And they're touching the skin of the participants. And as each time the rod touched your skin, a light came on. They would see a light, right? Maybe they had glasses on, they would feel it. And at that moment, they would document, like on a scale of 0 to 10, the intensity, right? I don't know that they called it pain, but like how intense that stimulus felt. Nothing changed about the stimulus. The only thing that changed was the blue and red light. And the red light was scored way higher, way more intense than blue. So it's like we make assumptions about what we know, and that affects how we feel about certain things.
So it really is all in our head.
Yes, it is. It is. But that's not to say anyone is crazy or that it's not real or that we can't do something about it.
Yeah.
It's like the moment you know that, then you can start like downplaying that where I can talk to it. So I'm someone who is a manual therapist. I use my hands all day. And so when something happens with my hands, it feels important. And I call her worst case scenario Claire. She goes straight to the, and then I have to come back and say, like, you are safe. Like, you know how to work through this. Yes, you have neural tension. You have all the tools to get rid of that. I mean, I have to kind of like coach myself down. This feels really big, but you're okay. You know, you're safe. And So I think it's like it adds an element of like when we can recognize this feels important, because to me it, and it would even be like the same with someone who has someone in their family who's got a horrific disability related to some back injury or a disc, and when you feel that first little back pain, automatically you're going there, right? The fear around,
I mean, just like Uncle Randy.
Exactly.
Yeah.
Right? So it's bigger to someone who's got a representation of the worst case scenario versus someone who's like, it's just a strain, put a little,
Okay, I got lots of questions.
Okay.
Try not to derail us here. So earlier when you were talking about like the knee has damage.
Sure.
Right? Mm-hmm. Like in that example of the little boy falling off the bike.
Yeah.
Okay. But tissue damage does not equal pain.
Mm-hmm.
Or pain does not equal tissue damage. Is that right?
Yeah.
And then connecting that with, it really is all in your head. Like I'm just, I guess what I'm thinking about is the relational component of pain, in that, and maybe this is more true for some of the older generation, not throwing the boomers under the bus. My parents are boomers, I love them. Just thinking about how in order for pain to be legitimate, there has to be tissue damage.
Yes, you're talking about specifically like in the medical model how we handle.
And if you come in and there's nothing on the image, or there's nothing that we can diagnostically observe, then
it is.
Are you seeking drugs?
Right. So this is you are pointing to the biggest deficit in the medical model when it comes to pain, is that number one.
I knew I was onto something.
I would argue that many clinicians out there, not just physicians, although certainly some physical therapists, don't understand pain. And so when you are trying to make tissue damage equal pain and treat just tissue damage and inject, medicate, surgical procedure, all of those things so maybe those things are needed in some cases, but without also contributing favorably in terms of what you say, how you create a connection with a nervous system component of your pain along with those other modalities that may very well be needed, we're missing a huge component, and you end up with where we are, which is a pain epidemic and also an opioid epidemic, which I think we've worked to tackle. There's a lot of people intervening and helping, and there's some landscape change. We still have not taught people
about pain.
And I may even said this in a thing. It's like if a patient is coming to me with even just simple ankle sprain, just something of very, very acute, specific, we help intervene, we flesh out that swelling, that they're going to feel better. I am also teaching them about this greater concept of how your nervous system contributes to your pain, whether or not that's really important for this ankle sprain recovery, or it's important for them to know that every time they experience some pain, have some pain experience in the future, that they are better equipped. And so when I'm teaching, like I teach some of the pain science content at FranU, I'm like, you can't approach every patient from the like acute pain perspective. You can approach every patient from the more chronic central sensitization perspective, and everyone gets better. So you need to be having those bigger conversations even while you're flushing some swelling out of an ankle.
So let's see, how are we doing on time? All right, one more question. When it comes to treatment, and maybe this is next time, like what's kind of the status quo medical model treatment for pain, and then what would be what would it look like to have a more integrative,
a gold standard kind of Okay, so right now, I think the biggest hurdle is that, you know, we've talked about like just sort of these societal beliefs that we just sort of buy into a specific narrative. And I think for so long the physician was there's a hierarchy, right? And the physician is on top, right? The medical doctor is on top. So I still have people, even who know what I do or have had my help, we automatically go to this spot of like, I need to get an appointment with my doctor, and I probably need to get imaging, and there's this belief that that's what we funnel right into. So the risk with that in people who have a bigger nervous system component to their pain and less of a tissue, is that their needs will not be met, right? And so they're going to get this runaround, and they're going to spend a ton of money on imaging, on procedures, on things that don't work, and it is going to continue to facilitate this thought that I'm untreatable, I can't get through this, now this is going to be my life, sort of thing. My goal is that we start, and look, medical doctors are very good at what they do, but they are trained in medicine. So they're trained in, I'm listening to your symptoms and I'm gonna prescribe these medications. Or if they're a procedurist or a surgeon, they hear your symptoms and they say, here's what I can do in terms of procedures and surgery.
Right.
They don't have experience with conservative management of things. And I say that not because they don't have the capacity or they didn't have, they don't have the time to sit, I'm treating patients for a full hour. I'm treating clients for a full hour. So and that's sort of what it takes to get this narrative across in a way that you establish a therapeutic relationship and a trust. And so they're not equipped there. My goal would be that when it comes to a pain complaint that pops up, that our first call is not straight into the medical model,
right?
But that maybe everyone out there, much like we have a primary care physician, or we have a dentist, or that you have a physical therapist who's your guy, who's your girl, that you can reach out to and say, this is what happened, this is what I'm presenting with, is this something you can help me with, or what should I do? Because this profession that I'm in has switched into a doctoring. We have differential diagnosis. We understand, and we also know, hey, there's some red flags here, or this is out of my league. I got to get you in the right hands. So what ends up happening when that model occurs, where for your ankle sprains, for your back strains, for your thing, you're calling your PT first. We're also not flooding physician offices with things that can be handled.
Is that happening? Is that shift happening? Or is that what you would like to see happen?
I think that it is very slowly. Okay. I think I'd like to see it way quicker, right? But so like an example to me, taking like an ankle sprain again. As a clinician, as a manual therapist, as someone who understands pain, what I want you to do with that ankle sprain is compress it, immediately get rid of the swelling. If there's trigger points or tension in some things, we're going to work that out. We're going to give you, after that acute phase, some proprioceptive balance training, all of that thing. The last thing that I want you to do, unless there is a fracture or a severe instability, is get in a boot. And you know what people do when they end up at the orthopedic acute care or the whatever, is you get in a boot. And that physician doesn't say, hey, you should pop out of the boot every now and again and flush and wear a compression sleeve and do some balance training and, do some towel scrunches and teach your foot to remember to be a foot. No, they say, wear this boot for 6 weeks and then or 4 weeks, and then you can take it off.
Okay, I got to stop. I'm going to ask more questions.
I know. I'm sorry. That was a lot, but good.
So I think where I would go if we had time would be, I want to know, there needs to be like a treatment flow chart.
Yeah.
Or like, if you're here, then the first priority is like if you're bleeding, like triage. Okay,
absolutely.
You're bleeding out, we're going to stitch you up, and then we're going to treat the cancer.
Sure.
Right? So I
think the hardest part, the biggest hurdle, will be that patient narrative that we've all bought into.
Mm.
That you don't have. I mean, it's like even my in-laws or people who know me and they're like, I just need a call med, and I'm like, you don't need a call, and it's like, but that's what we go to, right?
Yeah.
When, and especially if we're fearful about what we're feeling.
So, and I wonder how much of that is just, I need somebody who I trust is an expert to tell me that I'm going to be okay, or that if I'm not okay, here's what is wrong with me. And even if that is incorrect,
Yeah.
it still provides this sense of like
Sure.
calming effect.
Yeah.
Like, oh, well, that's what it is. you
Yeah.
know? I remember this story. There was a young kid in the community who we were kind of mentoring, and a group of us were working out, and we were teaching him, how to do squats.
Okay.
And he was doing squats, and he was doing fine. And the next day, he was so sore that he was like, I gotta go to the ER. I gotta go. And we were like, bro, you're okay. He's like,
Right.
no, please take me to the ER. So
Yeah.
the guy, I think it was his foster parent, took him to the ER. And the doctor, they did an X-ray, and
Right.
it seems like the doctor's almost trying to find something.
Absolutely.
And it's like, it seems like that you've got some mild scoliosis. And this is, I kid you not, this is what the kid said to the doctor in her blood. So I've got a crooked back.
Yeah.
Like, that's
Well,
why
and
I was in pain.
Yes.
Yeah.
And in the hard part of a story like that, which is cute and funny, but is that tag, that label
Yeah.
sticks with people.
Yeah. I mean, I'm sure he's still thinking about
Oh yeah. Right. I know. Well, more to come
more to come.
with Amongst All Lamps.
Amongst All Lamps.
Norm and Claire. We're gonna just dress alike the entire next time we meet.